Good morning, I am Begoña Arribas, vascular surgeon and coordinator of Diabetic Food Department at Fundación Jiménez Díaz in Madrid. First of all, I would like to thank the invitation to this international congress to Dr. Piciorului, and we will talk about peripheral obstructive arterial disease in the diabetic patient. As you know, occlusive peripheral arterial disease is blockage or narrowing of an artery in the leg, usually due to atherosclerosis and resulting in decreased blood flow. Symptoms depend on which artery is blocked and how severe the blockage is. Despite increase in awareness and screening programs and specialized care teams in many developed countries, the global burden of diabetes and diabetes-related complications have increased rapidly over the past decade. There are wide variations in rates of major amputation across the world. Traditionally, we thought that neuropathy was the origin of diabetic foot ulcers, but nowadays there is an increasing proportion of ischemic or neuroischemic causes. It is estimated that in the middle and high-income countries, up to 50% of patients with diabetes and foot ulceration have underlying peripheral artery disease, PAD, whereas neuropathic ulcers are more prevalent in low-income countries. In patients with diabetes, PAD may remain undiagnosed. There are many patients without significant symptoms such as claudication or rest pain, which may rapidly progress to limb loss, and diagnostic tests may be less reliable. It is important to identify PAD in diabetic foot ulceration as soon as possible, because presence of PAD is associated with increased risk of non-healing ulcer, infection, and major limb amputation, as well as an elevated risk of cardiovascular morbidity and mortality. Even more, the prognosis of a patient with PAD and diabetic foot ulceration requiring amputation is worse than many common cancers. There are several guidelines for the management of patients with PAD. However, most of them fail to include a diabetes subgroup. There is no doubt that patients with diabetes and PAD represent a special one, with different clinical presentation, natural history, and outcomes than patients with PAD without diabetes. PAD is more common in diabetic patients, affects younger individuals. Lesions are frequently multisegmental and bilateral, more distal, presents more medial calcification, have impaired collateral formation, and patients frequently present severe tissue loss without significant symptoms, which may rapidly progress to limb loss. Let's move to talk about the arterial medial calcification in diabetic patients, responsible of typical image vessel that you can see in foot X-ray on the right side of the slide. On the left side, we can see the difference between common atherosclerotic and Munkever disease. In that stage of atherosclerotic disease, we can see an eccentric plaque with deforming lumen and vessel stiffening. The calcium deposits are found in a subintimal layer with lamin stenosis. Munkever sclerosis is a form of atherosclerosis where calcium deposits are found in the muscular middle layer of the wall of arteries. Vessel becomes more stiffening without lamin stenosis. The International Working Group of the Diabetic Foot has published guidelines which you can obtain in this web translated in many languages. We can review an update of the diagnosis, prognosis, and management of PAD in patients with a foot ulcer and diabetes. They are followed the GREDE methodology to write recommendations. In a person with diabetes and no foot ulceration or with foot ulceration, we have to do a clinical examination to identify or exclude PAD. Appropriately performed medical history and clinical examination can suggest the presence of PAD, but their sensitivity is too low to rule out PAD in all patients. Many patients with diabetes and PAD have few or atypical symptoms. The positive symptoms may be related to the presence of neuropathy and loss of pain sensation. Individuals with PAD have an elevated risk of other cardiovascular disease. Links to the presence of PAD are absent peripheral pulses, presence of femoral broods, and slow venous filling time. In patients over 50 years, more than two-thirds of patients with PAD had a detectable pulse. Although in the presence of significant ischemia, the presence of palpable pulse cannot be used in isolation to exclude PAD. Slow venous filling times, pallor, or decreased temperature may be unreliable due to the arteriovenous shunting, resulting in a relatively warm foot. As clinical examination does not reliable, in addition to clinical history and examination, we should perform an objective evaluation in all patients with a foot ulcer by determination of ankle or 2 systolic pressure, ankle or 2 brachial index, and pedal Doppler arterial waveforms. But determination on ankle or 2 pressure or index, especially in ankle determination, can be artifacted by medial arterial calcification, resulting in a rigid leg artery or digital artery and a false elevated value. A triphasic pedal Doppler arterial waveform with Doppler appears to provide stronger evidence for the absence of PAD. Pedal Doppler arterial waveforms and 2 brachial index are the most useful non-invasive tests to select patients for diagnostic imaging. There are not a single measure with accuracy for the prediction of healing. The most useful tests for predicting healing are 2 pressure and transcutaneous oxygen pressure. There are poor chances of healing and increased risk of amputation in patients with the opposite situation, and we suggest consideration of revascularization in this patient. Also, we can use the Wi-Fi classification system that categorizes the patient ulcer, named by W, severity of ischemia based on non-invasive test, and severity of foot infection. The scoring system of Wi-Fi classification is used to guide us in estimating the risk of amputation and potential benefit of revascularization. Then, revascularization or not, always consider urgent vascular imaging and revascularization in a patient with a diabetic foot ulcer and severe PAD. Studies suggest that an aggressive approach with early revascularization might improve outcome, supporting the strategy of the sooner the better. However, there are findings that up to 50% of patients with diabetic foot ulcer and PAD who do not undergo revascularization may be expected to heal their foot ulcer. That suggests the policy of no one-size-fits-all approach, and each case should be evaluated on an individual basis. Thus, they recommend consider revascularization in all patients with PAD and diabetic foot ulcer, unless the test results when the ulcer does not improve between 4 to 6 weeks despite optimal management. Do not assume diabetic microangiopathy is the cause of poor healing. When we consider revascularization, vascular imaging should be performed to define presence, severity, and distribution of arterial stenosis or occlusion, with detailed imaging of below the knee and pedal arteries, like polar Doppler ultrasonography, computer or magnetic resonance angiography, and intraarterial digital subtraction angiography. The aim of revascularization in patients with PAD has been to achieve inline pulsatility flow of the foot, usually by targeting the best vessel available. More recently, an angiosomet direct approach is recommended. According to angiosomet theory, the foot can be divided into three-dimensional blocks of tissue, each with its own feeding artery. Direct revascularization will result in a restoration of flow through the feeding artery to the area where the ulcer is located. That is, in theory, more effective than simply targeting the best vessel, which may not supply the area of tissue loss. There is still no consensus on the most appropriate approach to the revascularization. Endovascular, open surgery or hybrid techniques have its advantages and disadvantages, and it is not possible to compare both groups. Decision must be based on individual factors such as morphologic distribution of PAD, patient comorbidities, and local expertise. A successful distal venous bypass can result in a marked increase of blood flow to the foot, but general anesthesia is usually necessary and a suitable vein as a bypass conduit should be present. On the other hand, an endovascular procedure seems more attractive, but may lead to worse outcome when an open procedure is subsequently performed. Plus, revascularization is only a part of the treatment. Other important points of care include treatment of the infection, wound debridement, biomechanical offloading, control of blood glucose, and treatment of comorbidities. Remember, time is tissue. Patients with all of that may not be suitable for revascularization, and the decision to proceed to primary amputation or to adopt a palliative approach should be made in conjunction with the patient and a multidisciplinary team. It should be taken into account that some severely ischemic ulcers heal without revascularization. Provide intensive cardiovascular risk management for any patient with diabetes and an ischemic foot ulcer. As a conclusion, there are many questions to solve: the best test, the best treatment, when, what, and how to do, but there are no doubt the patient must be treated by a multidisciplinary team as part of a comprehensive care plan. In a good organized team. Many groups describe their team consisting only of a vascular surgeon and a podiatrist. Others argue that the team should be broader and include orthopedic, infectious disease specialists, and endocrinologists. Although peripheral neuropathy has a central role in diabetic foot lesions, vascular specialists maintain a critical management role. As a rule, severe ischemia of lower limb generally requires an aggressive revascularization strategy. Thank you very much.